Hello, everyone. Today, we had the privilege of speaking with Dr. Tien, a true leader whose impact spans from the operating room to the front lines of public health policy. Dr. Tien is not only a distinguished trauma surgeon and president and CEO of Orange, but he has also played a pivotal role as the chair of Ontario's COVID 19 Vaccine Distribution Task Force. A dedicated researcher, Dr. Tien has also made significant contributions to pre-hospital care, advancing the evidence base for trauma management and emergency medical services. Today, we'll explore what he thinks about TXA in the pre-hospital setting and how patient handover and early hospital notification can impact care greatly. The following is Dr. Tien. We hope you enjoy.
What would be most relevant from our perspective right now is we're looking at ALS-PCS change coming in February, where TXA is being implemented into frontline scope of practice for land ambulance. For us, it seems like a long time coming. You hear the sentiment on the road, and a lot of the paramedics will say, we've been asking for this for a long time. And I imagine that the reservation is likely evidence-based, and we're building up towards something that makes a difference. So I'd love to hear your perspective of where it fits and the benefits from a land ambulance perspective, and maybe why now compared to where we have been.
I actually can't speak to why it's taken so long. I think there's always been a sense that since 2010 that the administration of TXA saves lives, particularly in bleeding trauma patients. That's what the studies will say. And there was also a sense that the earlier it's given, the better. And so certainly at the trauma center point of view, it was incorporated shortly after the CRASH 2 trial as part of the early management of the massively bleeding patient. And I think on the military side, we incorporated it, and I can't remember the exact date, but shortly after that in our pre-hospital, or at least in our what we'd call our Role 1 facilities protocol, but pre-hospital as well. And there was looking at auto injectors as well, but for sure the IV administration in the austere circumstances.
Because that brings us to a great point, because we can do it by the intravenous route, the intraosseous route, and intramuscular. Would you preferentially say there's one superior method over the other?
Well, I think if you can give it IV would be preferred. That's what the studies were done using the intravenous route. Always best to do it the way the studies gave it. But I think if compared to not being able to give it, I think most people would say try to give it by some route. IM auto-injector would certainly, I think, be better than nothing if you had no other alternative.
I think that's such a good point, is the time frame. I think it's easy in pre-hospital emergency medicine to get caught up in seconds to minutes versus minutes to hours. And I imagine maybe some of the perspective is, well, how long will it take me to do an IV? Would you say that's relevant, or likely more just along the lines of the study of it was studied IV, then IV would be the most appropriate? 10 to 15 minutes difference is not going to be the big difference between the impact of TXA, the end outcome.
I think it really depends. I guess it depends on how far away you are, right? And so if you happen to be right next to a trauma center, there might be an argument just to load and go. But certainly as the distance extends itself, and we know the GTA is a big city with two relatively central located trauma centers and bad traffic, the further out you get, the longer the drive time, the more there's an argument to giving it.
Because what does it actually do? Why does it prevent bleeding or stop?
It's an antifibrinolytic. And so the idea is that, like in any normal person, when you clot, right? So when you start bleeding, you have an injury to your blood vessel and your body tries to clot. And then, but if it continues to clot, you have a problem. You clot everywhere, and you have a major problem with that. And so there's a balance between clotting and clot breakdown, which is fibrinolysis. In trauma patients, one of the mechanisms they believe of something called coagulopathy is where your blood is too thin and you're bleeding, is that the clots break down too quickly. And so if you give an antifibrinolytic, it will help, I guess, preserve the clot as appropriate.
I think back to the time piece. So another interesting piece of it, we're looking at hyperfibrinolysis, and we're looking at trying to stop that. within 3 hours appears to be the sweet spot. Is there any evidence that says that in a half hour from trauma, because sometimes we're going to be on scene immediately after this has happened, have those timeframes been investigated as to, does it matter? 3 hours is important. Is there an increasing effect when we give it even earlier?
Yeah, I think so, because there are other instances where fibrinolysis is documented with like different tests. So there's a test called thromboelastography. And so if they document hyperfibrinolysis outside of the TXA window, people would give TXA. So it's not like it's within, there's no magic that says within 3 hours of trauma, that's where it's best. Like if you have laboratory evidence of hyperfibrinolysis, people would generally administer TXA.
And that's good to hear, because I think that's some of the, not pushback, but maybe concern we get is it's an easy sell from the educational perspective around that major trauma patient. I think everyone can agree that the person who is going to the trauma center likely has a huge amount of bleeding. TXA makes sense in, but, and correct me if I'm wrong, the perspective is that if there's a chance you're bleeding and you're showing those signs of hemodynamic instability, the benefit outweighs the risks, regardless if you're presenting like that major trauma patient, it's the risk of bleeding instead.
That's right.
I think that leads us into probably maybe another controversial point around fluid administration. And some of the questions we get maybe don't align with some previous educational practices where people say, well, when I went to school, I was taught 2 18-gauge IVs, and I'm going to bolus as much saline into this patient as possible, which does maybe seem counterintuitive when we're looking at promoting clotting with a medication like TXA. Is there a potential risk for us in that huge, massive bolus of a normal saline, for example, to the trauma patient?
Yeah, I think the feeling is that we're moving away from saline and we're moving away from large boluses for a couple of reasons. But there's the cohort of patients with penetrating trauma, right? Say you get shot or stabbed in the abdomen or the chest and you hit a major blood vessel and it's bleeding. So the clot tends to be a little more stable when your pressure is at 140. Right. There's a notion that you have this one vessel or a couple of vessels that are bleeding. The pressure went down, so it allowed a soft clot to form. And if you resuscitate substantially, you have a hydrostatic pressure that will pop the clot. So that would be one in penetrating trauma. There's also the idea that if you give a lot of saline, you dilute the clotting factors and you get a dilutional coagulopathy. The thinking is a little more unclear with blunt trauma. So what we also know with blunt trauma is that if you have a brain injury, which often comes with blunt trauma, you don't want them to be hypotensive.
Right.
And so this notion of permissive hypotension is really more of a thing with penetrating trauma than blunt trauma.
I think that's the nuance, because I have this dichotomous view. It's don't do saline or do saline, but like you said, what if it's blunt? What if it's penetrating?
Right.
And what if I do leave them hypotensive that leads to ischemia? Because correct me if I'm wrong, there's a certain time limit where we could do permissive hypotension in penetrating trauma, because if it prolongs it, you need to force it.
Well, I think the study that was done by a guy named Maddox in I think in 94 was this idea that in an urban center where you have short transport times, you're better off leaving fluid resuscitation till they get to the operating room for those that have a penetrating torso injury. And then you get them to the OR quickly to stop it, as opposed to doing it in the ambulance, popping the clot and having them bleed more. But it changes a little when you're in a rural setting or in a military setting where your transport times are longer.
Yeah.
Or if you have hemorrhage control. So say you have someone who's bled from, say, a traumatic amputation in their legs, but you've got tourniquets. So you can't really pop the clot because you have your tourniquets on. But it's really until you get definitive hemorrhage control.
Key point.
Yeah, and I think that makes sense from it's context specific.
Yeah.
The person matters, the type of injury matters, the time matters. And we see a lot of that now with our directive changes where some people have 30 minutes, some people have 60 minutes to get to the trauma center. So probably an important factor for them to consider. So say we've got a longer transport time, we are considering fluid bolus for that patient. How risky would be the potential for hypothermia while administering that medication?
That's a big one, right? So the hypothermia was part of that lethal triad of coagulopathy. Hard to manage the acidosis, but the hypothermia in the pre-hospital is a major problem. And cold fluids, when you think about hypothermia, it's probably when you stick your hand in an oven, it's warm air, you don't burn yourself because of the heat density of air. But when you stick your hand into boiling water, you burn yourself instantly. So fluid has the ability to raise your temperature or lower your temperature much more substantially than air. And so if you infuse cold saline, you will drop their body temperature very quickly. And their ability to clot after 32 will be diminished substantially.
So I think if I'm correct in what you're saying is that sometimes we may be looking at even a day like today, it's not too cold out, and I think I'm not cold, but that truck or the fluid in the truck is still cold enough that it could have a dramatic impact on that patient.
Think about it, right? We're happy at 37 degrees Celsius, right? Outside, it's probably 5 degrees Celsius. Yeah. That fluid, even if it's at room temperature at 20, will drop your body temperature down substantially if you give enough of it.
How often do you think in your work at the trauma center are you seeing patients coming in that are experiencing a degree of hypothermia as a result of their trauma they're brought into the trauma center?
And geez, you're asking me such hard questions. I actually forget the data. Like we actually did a study and you were talking about Dr. Deleuze. We did a study looking at that, and it's a substantial number that come in, say under 35 degrees Celsius. And it really is trying to raise that awareness. When simple interventions like for us in the trauma center, when someone is in wet clothes, for example, that wicks away body heat very quickly. And that can be environmental, like from snow or rain, but it can just be from blood, right? And getting them out of their wet clothes, getting warm fluids, putting on a bear hugger or warm blankets make a huge difference to hypothermia. And I think that awareness is very important for all trauma practitioners.
Yeah. We've been doing a large push in our education to speak to that because we think about the human factors, like we start cutting off their clothes. Then what if it's in the middle of the summer? We get hot, nervous, and sweaty when we put on the AC. This is a natural.
Right.
Yeah. Then we're all like, oh, we just horribly impacted the patient. And I believe some services are actually getting like foiled blankets now and like equivalent to the bear huggers, which is amazing. And our colleagues on the TAC teams and the Army, they did live cadavers on pigs. They said, watch what happens if I leave one arm or leg out. Pig's temperature just drops and they start bleeding excessively. So I'm glad you're talking about that. But if we are going to administer fluid, is there a way we can mitigate the hypothermia?
I think you're mitigating, like the administration of fluid is to mitigate hypotension that, to the point where they're not perfusing their brain. So I think you're not trying to get them to 160 systolic. You're just trying to get them to perfuse their brain. So if you administer to a return of their radial pulse, that's what we used to teach in the military. Like if you don't feel a radial pulse and you think their pressure is like 60 systolic, just try to get them up to 80 systolic. If you've got the benefit of a blood pressure cuff, you pick a lower target than 130.
That way could blow up the clots and lead to hypothermia. Because I don't know, I've seen people wrap hot packs around the saline. Do you think that would be beneficial?
I do. There's different ways to do it. In the military, the medics, if they were on winter exercise, would make sure that they had the fluid in their coats as opposed to out in the open. They would do a lot to try to keep them warm.
Yeah.
There's all these formulas for microwaving fluids, but I don't think we recommend that. But because you don't know how evenly it will heat up the fluid, right? But you certainly don't want to be administering fluid that's 10 degrees Celsius if it's been out in the ambulance that long. I think it speaks to making sure your ambulance is in a garage, that it's warm and it's heated, and the fluid is protected.
And I think that is one of the goals. The truck doesn't shut off, or it's supposed to not shut off. You keep that at a reasonable temperature. But again, it's that awareness piece of I need it to be at a certain temperature for a particular reason. I think, like you said, some of the low-hanging fruit, if I think the person can get cold, I should warm them. Or I should at least be mindful of the fact that they could end up getting cold. We talked a bit about cerebral perfusion and head injuries being common in blood trauma. And I guess that's the other question I'd have is as we move through it, we talked a lot about maintaining perfusion, making sure that pressure is enough that the brain can be perfused. What is the importance of oxygenation along with that? So is it a kind of double-edged thing where we have to make sure we're getting enough oxygen plus the perfusion? Is just the perfusion important?
Oh, oxygenation for sure as well. It's really the two, right? They talk about hypotension doubles it. Say you go from 30 to 60%, and hypoxia amplifies that even more. So
if that's the case, what would you say is the ideal airway management strategy for these patients? Knowing that it's a complicated patient. So I know not everyone is the same or going to present the same, but multi-system trauma or blunt trauma with head injury involved. What is the ideal way to maintain that oxygenation on a busy call?
I think if you have a severe brain injury and you're able to get to a trauma center quickly, I think it's really making sure that they've got 100% oxygen on, that they're not obstructing with their tongue and getting them there quickly. I think once you start getting into longer transports, and it's hard to, I don't think it's one is long and one is short. I think it's a continuum. There's probably some benefit in maintaining their airway also, because if they vomit, you need to protect their airway, right? Which is one of the major reasons why we do that.
We pivot and we look at pelvic binders, because I know we've done a large emphasis on pelvic binders, and I'd love to hear your perspective. Are they commonly placed incorrectly from the pre-hospital setting when you see them in the trauma center?
I guess my measure of, correct placement is how often does the pelvis look closed, right? Because what will happen is, so I actually think generally the binders are doing what they're supposed to do when you guys apply them, which is it looks like the volume is closed somewhat. So whether or not all your landmarks are 100% accurate, we're not really looking at that. It's just, does it look like you've closed the volume somewhat? And I think generally that's the case. Like I rarely see a pelvis that's completely splayed open.
And I think when we go back to timing, that'd be the other piece that we're trying to push forward. How important would that be, that pelvic binder, especially in someone with the suspicion that their pelvis might be fractured? How critical is that from a time perspective? Is it an on scene? Is it an en route piece?
I guess the question I would have, I hate to answer a question with a question, but I guess my answer would depend on how easy would you find it to put a binder en route in the back of an ambulance.
And that's a great question. A lot of it is resource dependent. I think it goes back to what you talked about with time as well being a factor. If I'm alone in the back of the truck for 60 minutes, that's a totally different. I think what I'm hearing you say is it's probably context related. It doesn't not have value. It just depends on how easy it will be to do it in whatever setting it's going to be.
And how much of a delay would it be to do it at the site, especially if you're really close?
Yeah.
Maybe you just load and go versus if you've got a longer transport time, I think it would make a bigger difference. Like the pelvic binders make a difference for venous bleeding for the pelvis, but the big arterial bleeds where they're very unstable, it doesn't do as much. It might help a little, but they still bleed massively. Right?
So getting there is probably still the key. Yeah.
I love that because we're operationalizing that. From a surgeon perspective, is the only way to correct that arterial bleeding just surgery?
No, in fact, it's usually angiography. We go to interventional radiology, so we can temporize by packing the pelvis. It's like putting additional pressure on the bleeding vessels. But if they're bleeding from one of these, what they're called branches of the internal iliac artery, usually we like to go to angiography for those. And that there's a bit of a setup. And these days, there's more and more operating rooms that are what they call angio capable. So we would go to the operating room, temporize while radiology comes up, and then would organize the embolization of the pelvis.
If they're on like a blood thinner, like Coumadin, Xarelto, would that impact TXA's effectiveness, or does it still work?
Nope, it's still.
Yeah, because we get that question all the time. And that's one of the best thing about the drug. It's quite safe and effective, and it works regardless of the meds you could be on.
So a question around, it's hard for us to give an answer sometimes to paramedics. And again, context is important, but a lot of times people are coming to us with challenging cases. You're looking at someone who's got multi-system trauma. Often blunt is more challenging, we find, for the medics to deal with the associated head injury. And we find that you have an agitated or combative patient, and it doesn't really fit. We've got offline medical direction. very specific directives, and not one really fits well for that patient. And I like the theme that we've been talking about is getting them to the trauma center is likely the key here. So when they're looking at doing that safely, do you have a perspective or maybe a preference for what sedation looks like for those patients when they're agitated or maybe difficult to manage and it's prolonging the ability to get them there?
If they're really agitated, you need to be able to treat them, but transport them safely, and staff have to be safe. Sedation is a requirement if someone is super agitated, right? For the sake of the patient, but also for the safety of the staff.
Yeah, because that steps into we're getting ketamine for analgesia, which I'm sure you recommend for trauma, just because it can increase their blood pressure and it works quite well. But they're also removing our blood pressure parameter for fentanyl because it's not truly vasoactive at the dosages we give. What would you think about the multimodal approach if we came in with a trauma patient, they had some fentanyl and ketamine? Do you think that's a good kind of cocktail of medications to achieve analgesia?
I guess it depends on how much time you have. I think multimodal analgesia, I think, takes a bit of time to administer and dose. So I wouldn't want you to sacrifice that from a time point of view. It's something that you'd be administering hopefully en route as opposed to there. And so I guess it would depend on how long your transport time is. But in general, I think multimodal analgesia is the way to go from a pain control point of view.
And just thinking, because we get this question too, and I'm sure I know your answer. If they had to pick between TXA preferentially or the analgesic drugs, what should they give first?
TXA for sure.
Yeah, for sure. 100%. What about the pelvic binder? Where does that lie? Does that trump TXA or what?
Geez, that's a hard question. I don't know if there's any data to support either one. My personal preference would be to give TXA.
Yeah.
Only because I don't know if I've seen a study where patients were randomized to a binder versus no binder and showed a mortality difference, whereas the evidence is pretty clear on the mortality benefit of TXA.
That makes sense. Especially if it's difficult to put on, where you can just give the injection of TXA, then yeah, that makes sense. I'm trying to think anecdotally, is there any major vessels that you commonly see again and again from penetrating blood trauma that are disrupted if you cut them open?
The aorta, for example, can be injured, but we don't generally see them because when you rupture your aorta, you're generally dead. So there's the contained rupture, which we'll see, but they're usually not massively unstable from that. If you rupture your aorta, that's it.
Yeah.
So like the common ones would be actually smaller vessels because they actually survive long enough to get to the hospital. And so in the chest, it might be an intercostal, like the arteries between the ribs. With fractured ribs, you've lacerated an intercostal artery.
Right.
In the abdomen, like blood trauma, it's usually the liver and the spleen that are bleeding. And so they are the ones that survive long enough for us to go to the operating room. And then sometimes it's the mesentery, like the blood supply to the bowel, that's cut as well. But generally the big vessels, when they are cut, they generally bleed a lot and they don't make it to the hospital in general.
That kind of goes with our education. I think it's almost half of the patients bleeding from trauma don't make it to the operating.
That's right.
And there's not much we can really do besides TXA, especially if it's internal. Like, how do we treat that?
Well, and most people will say that's the goal of prevention. And you guys have a large advocacy role as well. Paramedics on TV, drive sober, drive alive, wear your seatbelt. All of these things are actually the way to prevent that immediate causes of hemorrhagic death because they don't make it to the hospital. They're these big vessels. And so prevention is probably the best way to go for those. And vehicle design.
Yeah. Which I'm sure has continues to make a difference year to year.
That's right.
So say we don't. So I'm the blunt door penetrating trauma patient who I do have one of these major ruptures. Any benefit to TXA when I'm already in cardiac arrest from my trauma?
Probably not, right? Like they've basically exsanguinated. It's not as helpful because you'd have to replace that volume and hopefully that they've clotted. But generally they're so deranged metabolically that they're not going to clot after that anyway. So it might help a little, but there's no real evidence about cardiac arrest, post-trauma, and TXA.
Because I imagine the outcomes are
dismal. Yeah.
So if our focus then wouldn't be TXA on traumatic cardiac arrest, would you recommend just chest needles of showing signs of tension pneumo, binding the pelvis, maybe some fluid?
like a traumatic cardiac arrest, I think is really about the stuff, what's easily reversible, I think is make sure your airway's in the right spot and then really oxygenate and make sure they don't have a tension. Like they have a true cardiac arrest from trauma, it's blood trauma. The prognosis is really bad if it's not something like a tension pneumothorax. And in penetrating, it's bad if it's not something like a cardiac tamponade.
That speaks to, because we saw a directive change recently where it talks about penetrating trauma patients. If we can get them to the field trauma hospital or field trauma center, then we can transport them if they're in asystole within that 30 minutes. Does that work around, I guess, what we've been talking about is we can get you there quickly and maybe we can fix the underlying problem. Otherwise, we can't get you there quickly. The outcome is likely to be very poor.
Yeah. Like I think asystole has a really bad prognosis. I think if you've got, especially in penetrating torso trauma, if you've got, say they're in PA arrest, so you've got a nice organized cardiac rhythm, but you can't feel their blood pressure.
Yeah.
Those are the ones, particularly in penetrating trauma, that we feel if we get them really soon, we can change their outcome. Right. Ideally, it's because they have tamponade. We open their chest and release the tamponade. They have a pretty good prognosis if we get them quickly.
So you're working on likely mechanism to make that.
Yes. Once you open their chest and you realize they don't have tamponade, their survivability goes way down.
I know we all love saying it in the healthcare profession, like removing silos, but we always like to emphasize, why is it so important for paramedics to respond early to the trauma center to say we're coming in with a 40-year-old patient? Why is that important from your side of things?
I think it's preparation, right? I think when you guys go on a call, the more information you have so you can organize what you're going to do when you arrive helps. It's that mental model and mental preparation of what you're going to do when you arrive. I think it's the same thing in the trauma center. We have a model if someone comes in and you tell us their Glasgow Coma scale of 15, they got a broken leg. Our preparation for that is different than someone shot in the chest with a barely registered blood pressure. It's really the mental model.
Just from the patient handover standpoint, like Cyber's done amazing research with this, human factors and everything, because we're really trying to get this knowledge out there about Istanbul. And I remember just anecdotally, I had my report made in my head and I saw it written on the wall. They're like, do you mind following this template? I'm like, that's brilliant. I'm not prepared for it, but I'll do what I can. Because what happens if we give a disorganized patient handover to you? How can that impact outcomes?
I think it's both that you might miss a critical piece of intervention that you've done or a piece of information that might make a difference, but also it slows it down. I think the checklists are a way of making sure you hit all the relevant things quickly and efficiently.
And just like human factors, like, can you speak to some of the research that people like walking around the trauma rooms like multiple times, extra resources maybe impacting? Like, what's the role in having the right providers, the right equipment essentially organized in a way that you can grab it strategically?
Sure. I think there's a couple of things. One is about the equipment and one is about the right providers. So I'll start with the providers first. In Canada, there's a standard trauma team at some of these places. And with accreditation standards, they have different timeframes of when people have to arrive. So for example, as a trauma surgeon, we will divide the traumas as level 1 or level 2, and the level 1s being obviously the more acute, they're hypotensive, or there's like a gunshot wound to the chest and the torso, and having the right person there. So having the staff trauma surgeon there, so he or she can make a decision to go right to the operating room is really important, as opposed to having the patient arrive, assess, and then call that person in. Just causes unnecessary delay. I think having the equipment there is just part of being organized. When you need a chest tube, running and going to find all that stuff at the time it just induces stress in everybody and it delays. And I think for a good paramedic, I think your kit is all organized in a way that's easily accessible and that you know where it is and what standardize what it consists of. I think the same idea for all the emergency type services.
And I think that's such a good point that translates well to paramedicine as it is. It's organized well, it's all in proper bags, and a good practitioner will know where it exists. But sometimes I think the gap does exist in the preparation. I know I have it, but it's in between 2 or 3 bags. I need to pull it all out. Do you think there is value in looking at mechanism and regardless of patient stability initially? And that's what I'm always interested by the trauma team, the trauma center is it's the preparation for the potential. Do you think there's value in even those patients who maybe are somewhat stable or a soft stable of getting the stuff ready just in case?
Oh, absolutely. I think that's just good preparation. It's about anticipation of what could happen. If you don't anticipate anything, then everything that happens is a surprise to you. So I think the good practitioner, you minimize surprises, and hopefully you've anticipated the stuff that might have surprised a lesser practitioner.
Is there anything from your experience in the Army that you could pull from the Army that we could apply to the pre-hospital setting here that would help patients?
Yeah, I think the Army is very focused on delay in transport. They really think a bit about first, what can you do right at the site with whatever level of practitioner you have, dealing with what are the most preventable causes of death, and then adding on modular pieces to say, and if you're delayed in transport, what can we add on in terms of modules for the more practiced practitioner? And so like they will basically start, they have this thing called tactical combat casualty care with what the actual wounded person can do, right? So the wounded person will put on their own tourniquet sometimes. And then what their immediate colleague, immediate friend can put on as a buddy aid and maybe reapply the tourniquet or so forth. But then they have different echelons. And so then they have the medic show up. And then as you get further out, and if you think a bit about, we're going to have a delay in transport, what that advanced care practitioner can do.
Right.
And it's targeted to the preventable causes of death. And they use technology, telemedicine. They might use some novel clotting factor or clotting dressings or so forth. And so I think it's a methodical way of thinking about different people who can provide care in different situations. And then it's about what are the preventable causes that we for sure have to address.
I think that's such an interesting point because especially in probably more urban settings, you might have 4 or 5 different ambulances on a call. So you've got varying skill levels, sometimes lots of people of the same certification level. I imagine you see that in the trauma center as well. How do you balance the idea that some of these will be very low frequency, high acuity calls, and you want maybe the most experienced person to be doing the intubation or the chest needle decompression for that patient, but also balancing the need for the less experienced practitioner to gain that experience as well? I wonder if you could share what that looks like from a top trauma team perspective. Yeah.
Well, I think ultimately the patient is at the center of what we do. If time is of the essence, it should be the senior person, the most experienced person doing it, because we want to give that patient our best go at it if time is an essence. I do think these days simulators and simulation are playing a more important role. And I think with educational design, for a lot of these, like intubation, these high acuity but low frequency skills that some of our practitioners might have to do, we can simulate it and have them practice it in ways that can improve their success rate without always having to do that intubation in the field.
Right. Yeah, I think that's such a great idea from the perspective I can build your competence, but still the most competent person is doing it at the time of need.
I think that you spoke to a very aggressive model the Army has and just very systematic. And correct me if I'm wrong, in Europe, they have a different model for trauma. It seems like they try to stay on scene longer and aggressively treat them well. But they also have physicians riding it, paramedics and everything. Would you see that be beneficial here?
Like the European model, there's a couple of things. And one is that in Toronto, it might be similar to the European models in that traffic is terrible, right? So some advantage of having the practitioner go out is that if you're not able to move quickly, and this is again speaks to that austere circumstance, you're able to provide care en route. The military model for this is that the platform that, say, the Canadian Armed Forces has chosen is a Chinook. And I don't know if you've seen Chinook helicopters. They're like a hospital in that they're huge and you can actually resuscitate in them. So when you talk to the military, it's really this model. It's not that you're not choosing between stay and play or scoop and run. you're scooping and running and playing at the same time because you're in an aviation platform that allows you to resuscitate. So you're basically bringing the emergency far forward. And so then as they're flying to the combat support hospital, they can be on the radio saying, okay, we've got gunshot wound, the chest tube output is this. We need to be ready to go right to the OR. So you just move that emergency resuscitation far forward.
And you spoke to geography. Like, how does outcomes change if you have a shooting here versus Sioux Lookout?
I read this paper that Ontario Health put out on care in the North, and that we have all these the excellent practitioners, but there's a lack of resources out there. And so they quote the preventable death rate, not just in trauma, but in everything, as being higher in the North than in the South. And I think the numbers I recall, and this report is a little older, I think it's probably 2015 to 2017, I can't remember the exact date, was about 6,000 preventable deaths per 100,000 in, say, the Northwest versus 2,000 in the South. And so I think that their point was we can do better, and we should think about how we can do better in the North, about supporting them, having more resources, taking some of the knowledge that the military, say, is having and applying it to the North about care in austere circumstances.
Yeah, it sounds like that is directly applicable, right? In the sense that you may not have access to a trauma center within that time frame. Instead of building one, how do we increase care on the go so you can load and go and play on the way to the right spot? Very cool.
What's the future of trauma care look like in Ontario?
Ooh, that's a tough one. I think trauma care in the South is excellent. Like when you look at, so the American College of Surgeons has this program called the Trauma Quality Improvement Program. And what they do is they take statistics from all trauma centers in North America and they compare them for like patients. And so like the Ontario trauma centers, and I happen to know the GTA ones, do very well, like well within the top 10% of all North American trauma centers for saving lives. And we get to a point where someone has a ruptured spleen, the system works extremely well. If they're up north, like Barrie, Perry Sound, they come by helicopter quickly. If they're in by Jane and Finch, they come to the trauma center by land ambulance very quickly, and it's very organized, and there's good communication, and the system works well, and the numbers validate that. I think your point is we have variations, though, in care, right? And so in the North, we could do better, and we should think about how we do better because they're all Ontarians. We should just think about how we can try to make it a little more equitable for care. So I think in the short term, there'll be a little more focus on how we can broaden it out. As people are injured further out from the trauma centers, how do we improve their care? There's more, in Southern Ontario, there's more level 3 trauma centers being opened up, which will broaden the reach of trauma centers. And then progressing to the North and better education, better training, better support for the rural trauma practitioner.
What a valuable statement, I think. Instead of focusing on how do we do the thing that we're doing really well better here, how do you expand that net so that everyone gets access to what you are doing well already?
And don't get me wrong, I do think we still have to push the boundaries of the acute care trauma center. But as a society or as an organization, right, there's research and then there's system design. And I think the rural and the remote communities need a little more investment in terms of better support from the South for training, for supplies, for communication, and so forth.
What's the low-hanging fruit that we could do that could help rectify some of those deficiencies?
Low-hanging fruit. I think there's best practices in the South that we could just bring to the North. So, for example, in the military, we have freeze-dried plasma, right? And we know that in the South, if you're bleeding, we can give you red cells, FFP, platelets, fibrinogen. In the North, we know that they don't have a lot of that. In fact, if you go to Sioux Lookout, they might only have 4 units or 8 units of pack cells and very little FFP. but we can take some of that knowledge. Like maybe we should be looking for freeze-dried plasma for them, right? And taking some of that knowledge that we have about austere trauma care and applying it to the north and offering it to the north.
Is Orange doing those studies right now, or are they carrying that?
So we are in the midst of looking at getting freeze-dried plasma. We're participating in a Canadian Forces study on whole blood in the pre-hospital setting versus red cells and FFP. And then, so I think as we figure these things out, and maybe as whole blood becomes, say it's approved and available, like I think having whole blood in the rural settings will be helpful, because then you don't have to give component therapy, for example.
It sounds like just another step into pushing some of the care so that you can prolong life to the definitive.
That's right.
Is it hard to store that stuff? Because I know that's always been the barrier. It's hard to store blood in the ambulance.
And that's why freeze-dried plasma, that's why the military is so interested in freeze-dried, because it's just powder. You can store it at room temperature for a 2-year shelf life, and you just reconstitute with saline. And so there's like freeze-dried plasma, there's freeze-dried fibrinogen concentrate. So there's more of an interest in stuff that you can put in a powder form and reconstitute, as opposed to what you normally see at the hospitals.
Very cool.
Has there been any pre-hospital studies on that?
I'm not sure about randomized controlled trials, but there is the use of freeze-dried plasma in the military setting.
That seems how it always starts. The Army gets really good at it, has robust data, then we copy it into our own setting.
Well, it's interesting. It goes both ways, actually, because like some of the civilian, you're right, there's stuff that you learn in military conflict that comes to the civilian side, but vice versa. Like when we were going to Afghanistan, the trauma system design for the Canadian Armed Forces was really inspired by some of the civilian trauma center design about data, trauma registries, and so forth.
Or we probably just have that bias. We're seeing what's coming to us, right? Not what's leaving from us to there. Yeah.
To wrap it all up, what do you think are the 3 takeaways that paramedics can do tomorrow to help treat patients and help facilitate patient handover to you?
I think the treatment really is keep them warm, get to the trauma center fast, and deal with the preventable stuff. So I guess I've overlapped. Keep them warm is one of them, but TXA, if they're actively bleeding, like tourniquets, direct pressure as appropriate, and then get them to the trauma center as fast as they can. I think it's important. Paramedics are the pre-hospital experts. And I think you can also advocate for the patients. We're all colleagues. If you see something, if you're concerned about something at handover is an important time to pass that on. Right. Because you guys are the experts in the pre-hospital, and we need to make that transition smooth.
That's awesome. I think that's valuable to hear. I think that's probably one of the most nerve-wracking things. A lot of paramedics, because they don't do that often, and they're walking in a room full of physicians, and they're nervous. They want to feel comfortable advocating. So I think that's such a good statement to leave people with, so that they do feel comfortable advocating for the person in front of them. That's awesome.
Thank you so much for everything.
Yeah, no, thank you. Really appreciate the opportunity.